afternoon, and thank you for joining the Superior Health Quality Alliance Nursing Home Leadership Roundtable, where we continue our series of turning your deficiencies into efficiencies. Today, we will be discussing F686 treatment and services to prevent and heal pressure injuries. My name is Constance Tetrov, and I am a quality improvement advisor with Superior Health Quality Alliance and accompanied by a few of my colleagues. Keisha Blesko, Tabitha Meyer, I believe is here, as well as our speaker, Miss Patty Leonard and Jana Broughton. We host these 1-hour sessions on the second and the fourth Wednesday of the month. The first half is a didactic presentation, then the remaining time will be for questions and answers. The PowerPoint presentation link will be dropped into the chat momentarily. Please use the chat box to share any comments, questions, and even resources during the presentation. Besides learning from our speakers, we learn from each other and our peers. Towards the end of today's event, we will post an evaluation link in the chat that will only take 1 to 2 minutes to complete. We use your evaluations to help us give you a better experience. Please help me in welcoming all of our guests and our only guests, and we will look forward to you learning more about F686 with Miss Patricia Leonard. We now go ahead, and the floor is all yours. Sorry.
All right, thanks, Constance. Thank you, everyone, for joining us today. I am going to put myself on, take myself off the camera. I managed to pick up a virus from my granddaughter, so I apologize for this today, but I think it'll be better for all of us. But we are going to talk today about F686, which is skin integrity and pressure injuries. And our objectives are to understand what is a pressure injury, to understand the difference between avoidable and unavoidable pressure injuries, talk about steps for prevention of pressure injuries, and some strategies to prevent receiving the F686 citation. I thought this afternoon that we would start with a poll. Can you get that up there?
Yep.
Yep, okay. So there are 3 questions. The first one is on a scale of 1 to 10, rate your comfort or satisfaction with your wound care program. The second one is just tell us how many residents you currently have with pressure injuries that you're caring for. And the third one is to provide us with some information on your biggest challenge with your wound care program. It's like we got about half the people responding so far.
Looks like we're still getting some responses in.
Yeah.
Okay, looks like we got about 65% right now. 100%, 100%, and just 92%. So we'll go ahead and end that poll for you.
Okay, what are the results showing us?
I apologize. Sorry, my microphone was off. The first one, I don't actually see the answer, but about 25%, 1 to 2 pressure injuries, 54% 3 to 5, and about 8% more than 5. We had about 13% saying 0 pressure injuries.
Okay.
The program with the biggest challenge with their wound care, 27% staff compliance, 18% with staff education, 32% with documentation, 5% with expense, and 18% with other.
All right. Thank you, everyone, for participating and giving us the information. That'll help us as we go through this. So, as usual, we have to start with a definition of what is a pressure injury. And I took this from the State Operations Manual. And the Feds, CMS, have adopted the National Pressure Injury Advisory Panel's definition. That's the NPIAP. And it states that a pressure injury is a localized damage to the skin and underlying soft tissue, and usually over a bony prominence, related to a medical or other device. It can be intact or it could be an open area. And actually, through the State Operations Manual, they still refer to them as pressure sores. The definition changed in April of 22. And those of us who have been around for many years, we talk about decubes. We talked about decubitus ulcers. Our families, our residents, and laypersons often still refer to bed sores. And it talks about possible locations over bony prominences, as we stated. So that would be your coccyx, your heels, hips, elbows, back of the head, ears, side of the knees, and shoulders. Just a quick story. Early in my career as a director of nursing, we cared for a little lady who had fallen in her senior apartment. And she laid for several days wedged between the toilet and the wall on her side. We admitted her from the hospital. And at that time, she'd had, I think, 3 stage 4 areas that had been debrided. And they were on her hip, her coccyx, the outside of her knee, and her ankle from laying in that same position for a couple of days before she was found. And I'm pleased to say that we were able to heal all those areas up. This is the F686 skin integrity pressure injury requirements from the state operations manual. And this is word for word. They expect that an assessment is done, and then the facility must ensure that the resident receives care. They say consistent with professional standards. So that's what the best practice is. And you need to prevent pressure ulcers from developing unless the individual's clinical condition demonstrates that they are unavoidable and that a resident with pressure ulcers receives necessary treatment and services consistent again with those professional standards to promote the healing, prevent infection, and prevent new ulcers from developing. Pretty much what you'd expect. Here's the intent. I'll need to heal those ulcers that a resident might come to us with and prevent any additional ones from occurring. And then should they occur, as quick as we can, get them healed. There were 2 terms in that definition that I thought we should look at: avoidable and unavoidable. Now, this is a lot of words, which is oftentimes in the state operations manual, but they are very relevant. Avoidable means that a resident developed a pressure injury and that the facility did not do one or more of the following. So that would include an evaluation, identification of risk factors, identifying and implementing interventions that are consistent with the resident's needs, his goals, and again, the professional standards of practice. You need to monitor, evaluate the impact of these interventions, and revise your plan and those interventions as appropriate. So unavoidable then is the opposite. You do everything you can. You developed a plan, you evaluate the ongoing effectiveness of it, you change it as needed, and the resident still develops a pressure injury. So I found this case study on an unavoidable pressure injury. Obviously, there's no guarantee that this situation or similar would not be cited. However, I believe with all the correct documentation that you could defend this one. It's a resident with advanced CHF, COPD, diabetes, anemia, low albumin and hemoglobin, elevated respiratory and heart rate, low pulse ox, even with oxygen, bilateral lower extremity edema, and he's unable to tolerate aggressive diuresis. So to me, sounds like he's in a very severe case of CHF. He is refusing a low air loss pressure mattress to his bed. He doesn't want to be repositioned. He has to sit in high Fowler's position. He can't tolerate anything lower. He cannot tolerate any oral supplements to address the low albumin and hemoglobin and the need for extra calories for healing. He gets a stage 2. In this case, the nursing staff educated him. They documented all their attempts to, put the head of his bed down, use a specialty mattress, and his continued refusals. I would think key to this would be the ongoing education, and that just one time offering and him saying no is not adequate. You need to keep offering those additional interventions and trying to find new ones for him. An additional background for skin integrity would be skin failure and the understanding that the skin is the largest organ of our body and it fails just the same as our heart and kidneys and liver do. And as we know, our older residents in our facilities are very much at risk. They have many disease processes. Some are maybe acute, like a sepsis or myocardial infarction, or many chronic illnesses that deplete and decrease the oxygen supply. Of course, that would be your kidney disease and heart failure. Oftentimes, there's a lot of edema and inflammation. And in some cases, skin failure, we can't stop it. However, there are many things that we can still do to prevent skin from becoming broken down. End of life skin failure, we also know that is sometimes we can do everything there, but it's unavoidable. That would be the Kennedy terminal ulcers that we see. So risk factors to the development of pressure injuries, we've talked about several of them already. But immobility, resident who can't reposition himself, obviously there's extended pressure to those bony prominences. The thin, fragile skin, edematous skin, places them at increased risk. Moisture, incontinence. Residents that don't take in much orally or are dehydrated, that also places them at risk. Shearing, those residents that you slide in bed instead of getting enough help to pick them up and reposition them, sliding. They get bumped during transfers, as well as residents who are paralyzed. Damage, and they can't tell us when they have no sensation, when they're starting, their bony areas are starting to hurt. Anytime a person is in the hospital for extended periods of time, even younger persons are apt and at risk for pressure injuries. If we think back to all the stories we heard early on in the COVID pandemic, all those people who got pressure injuries because they could not or were not repositioned. Again, the chronic illnesses that impair blood flow, dementia, Alzheimer's, any type of cognitive impairment, as well as a history of pressure ulcers, places a person at increased risk for the development of a new pressure injury. This is a non-clinical definitions for pressure injury stages. Why I chose to include them was I thought they might be helpful for education with your nurse aides when you're talking to families or residents. Stage 1, just briefly, is an area that's red, might feel warm to touch. Stage 2, it's more painful, may appear as a blister. Stage 3, they use the term here as a crater, and that's probably fairly descriptive, and people would understand that. And stage 4, obviously, is that very, very damaged area where you can often see muscles or bones or tendons when you look in the area. And then there are those wounds that are unstageable. We know there's full thickness tissue loss, but you can't see the bottom of the wound because it's obscured by slough, which could be yellow, tan, gray, green, or eschar, which is often tan or brown. These are photos from the NPIAP, the National Pressure Injury Advisory Panel, that shows pictures of the various stages that we just talked about. When you're doing staff education, I do like the real life photos. I think those are very descriptive and are helpful with your education. I just wanted to mention deep tissue pressure injuries, which is persistent pressure to an area and it goes all the way down. And generally they are non-blanchable areas that'll appear deep red, maroon, or purple in color. And there's sources at the bottom of almost all these slides for you. And then, of course, there are the other types of wounds. There's vascular, which could be arterial, venous, or mixed. Neuropathic diabetic wounds, moisture-associated dermatitis, which sometimes obviously can be confused with a pressure injury to the coccyx area, skin tears, and then mechanical device-related pressure injuries and mucosal membrane pressure injuries. I once took a citation several years ago in a facility for a wound on a foot. And at that time, we had a wound care physician who was caring for this 95-year-old resident. His notes all documented that the wound was arterial. It was a vascular wound, and we got cited for pressure injury. So with the help of some additional documentation from the specialist, we did appeal this, and they were able to turn it over. So that's why it's really important to know your different types of wounds. Additional information on how to prevent pressure injuries. I found this really interesting, and I did know this before, but when I read it, it's CMS defines pressure injuries on that list of what they call never events. They believe that pressure injuries, for the most part, are avoidable. And that the incidence of pressure injuries, those avoidable ones, is an indicator of the quality of care. And indeed, they do show up on your 5-star rating, as well as pressure injuries that occur in facilities can be the source of litigation, and they are very frequently cited on surveys. This is a very simple skincare protocol to prevent skin breakdown. It's again from the NPIAP, and it starts with admission assessments, which need to be thorough. You need to do a Braden or some sort of risk assessment to identify if you need to implement any other interventions to protect the skin. You need to have daily monitoring of skin with all cares, with prompt reporting of any areas that look red or pose a risk for breakdown. Again, positioning and mobilization, turning and repositioning those residents that are at risk according to their care plan and documenting that. Some facilities and some residents need an individualized turning schedule. For example, if they have a wound on their left hip, their plan might just be to put them on the right and on their back. You need to consider if it's appropriate to use pressure relieving specialty mattresses, pressure relief wheelchair cushions, or other positioning supports and wedges. We talked about preventing friction and shear and moisture. And I'm a big believer in keeping residents ambulatory as long as possible. So sometimes some therapy under Med B or even just range of motion will help this. We can't forget about nutrition, making sure and monitoring the resident's intake. Your dietitian should be doing this, checking weights, making sure that the weights are being done, whether it's weekly or monthly, whatever the resident's need is, or your policy says, tracking any lab work, what's the albumin doing, as well as the dietitian talking with the resident and the family to see if any supplements are needed. If they, enjoy milkshakes, that's even better still than an Ensure. Preventing the moisture, following your facility's practices for pericare. And then, of course, any types of treatments and skincare that's necessary, keeping skin moisturized with lotions, whatever barrier creams. Some facilities will put protective dressings on a bony prominence. Here is a tool from NPIAP, which goes through, says risk assessment, skincare, nutrition, repositioning, mobilization, and education. This would be a great tool to use if you wanted to do a quick review of your program, included in your copy. Use it as an audit tool. And of course, since I'm on the deal a lot with infection control, I had to mention monitoring wounds for signs of infection, but this is part of good nursing care. And the signs of infection could include thick yellow-green drainage from a wound, that foul odor, redness or warmth around the area, swelling, tenderness, and if a culture is done, the growth of some kind of an organism. Now, we know that all wounds can contribute to spreads of infection, which the symptoms would be fever and chills, change in mental status, confusion, difficulty concentrating, rapid heart rate, rapid respiratory rates, weakness, lethargy, changes in labs, and just general overall something's off. And maybe you can't even pin down what it is. Because we do know that localized wound infections can become worse infections. They can become bone infections, especially those heel wounds, osteomyelitis. And bloodstream infections or sepsis, that's a medical emergency. These are things that people die from. Any resident that has, or any person that has a pressure injury, you need to evaluate them and address any pain issues that they might have. Sometimes residents that are restricted and need to be in bed so that they can maintain their positioning to prevent further breakdown or relieve pressure from an open area, can become isolated and are apt to be depressed. Prolonged treatments, these are very hard on staff. Some dressing changes can take 2 staff and they can take a long time. So in addition to that, that's expensive. And plus all these wound care products are very expensive as well. And anytime that a resident has a pressure injury, it contributes to the ongoing and increased debility and frailty of our elders. So I'll touch real quickly on treatments and plans of care. I was overwhelmed with the many options and different types of dressings and creams and ointments that are out there to treat the wounds. And it seems like a lot of different providers and nurses have their own preferred ones. Some, like the Duoderm, some like the TheraHoney, some like the Alevin. And it just gets really, really confusing to keep track and know what's being effective and what isn't when orders keep changing frequently and there are so many choices. There are recommendations out there to consider using a formulary of products, picking one company and going with their formulary of items that they have. That way, you know for sure that they're all going to be compatible, that they're going to work together. And generally, those companies will come out and they will give you an algorithm or a grid or guidance. So if your wound looks like this, they may suggest that you use this type of wound or this type of cream. It will save space and cost. There's nothing that made me madder was going into the back of the cupboard where all our wound care supplies were and finding a whole lot of really expensive items that were expired and we had to throw out. And at the back under our resources, there are 3 articles that I referenced that talk about a formulary. I am not recommending any one of these at all. There's just some information for you that you might want to consider. And obviously you need to follow your physician's orders for treatments. Documentation of the treatment is very important. Keep your care plans up to date. And in some facilities, they're lucky enough to have a wound certified nurse. I think that's great. And in some cases, if you have a really, really challenging wound and you have the availability, you might want to consider a referral to a wound care clinic. And I do know those are hard to come by and transportation is always a challenge. So we have another poll here, Constance.
Getting ready.
All right. Does your facility have a standard set of skin protection interventions? So that would be you're admitting a resident and he's very debilitated. What kind of things would you ordinarily put in place? So it could be an order set, it could just be a cheat sheet. And then do you use a formulary? And if you do you find it helpful?
Okay, we got about 41%, 17 out of 19, 89% answered. The first question, 90% say yes for they have a formulary for wound care products, and 100% of the 21 out of the 21 answers say that they feel it's helpful for staff.
All right, very good. Thank you. I
Good.
appreciate the feedback there. So part of the goal with this presentation was to give you some material that you could use to work with staff, to do some in-services and education. So I included 2 case studies. I'm not going to talk about the first one. It's in the slide deck for you to use. But the second one, I think, is somebody that every facility sees frequently, your elderly resident that's been in your building for many years. Progressively, dementia is progressing. He's no longer able to communicate. He's losing weight. He's totally dependent on your staff. So if I were doing an audit and looking at this resident's care plan, his plan of care, what kind of things would I see? So I'm assuming that, he's getting skin assessments every week and with measurement of any wounds. He has a current Braden scale or other risk scale done, and that appropriate interventions or approaches, as I learned yesterday at Joint Provider, need to be included on that plan of care. Staff needs to be looking at his skin daily, some kind of turning and repositioning plan. Maybe he needs to have limited time sitting up to prevent shear. Depending upon his skin condition, you might have a specialty mattress, definitely pressure relief in the wheelchair. Does he need heel boots, positioning wedges? And as we've talked about before, making sure that his skin is moisturized. Skin and clean, keeping skin clean and dry, those protective dressings, barrier creams, looking at his nutritional status. I'm assuming it's declining. Does he need supplements? Some providers add vitamins. What about his plan for pain? Therapy again, range of motion, will that help? And then communication with the provider and the family, updated care plan, and depending upon obviously his clinical condition and his skin status, does he need a wound care consult? If you would mind adding anything more into chat that I didn't mention. One of the other goals of this program is to help each other. Everybody is out there learning and doing different things. And by sharing that just makes the things we can do to help our residents, just makes our toolkit just that much bigger. So if you could put anything into chat that I didn't mention, that would be great. We can all learn from each other. Okay, well, I'll move on here. If anybody thinks of anything later they would like to share. Oh, did we get something?
Regular education for all staff on skin health.
Oh, very good. And we do talk a little bit more about that in a few minutes, but I agree, that's very important. So thank you.
Getting those first assessments of the skin done within just a few hours of them coming into a facility too. I know it's really difficult, but getting that done right away
Absolutely.
and looking at it multiple times through that first 72 hours is really, really important because they can develop injuries from the hospital, from other locations that they came from, and you want to get that information right away.
Yeah, no, I definitely agree with that. And I think probably a lot of us have been caught by that as well. So we're going to spend several minutes here talking about the common F686 citations. It is in the top 10 cited F tags from Michigan, Minnesota, and Wisconsin, and those are the areas that Superior Health supports. In Michigan, when I last looked about a month ago, there were 13.8% of all providers or nursing homes that received this citation. Minnesota was less at 6.3, and Wisconsin had 11.9. And this data came from either recertification or complaint surveys. And the scope and severity varies greatly. They can be from no harm all the way up to immediate jeopardies, which I've read as well. And there are oftentimes, if there's citing F686, they will often also cite one of these other tags. Now, I can say that I've seen pressure injuries cited under 684, which is quality of care, but in general, they are under the 686. So oftentimes they'll obviously look at your care plans, make sure if your physician wasn't notified, that's a 580. Again, looking at the resident assessment, 636. Quality of life, 675, and 676 talks about resident receives appropriate treatment and services to maintain or improve his ability to carry out daily livings. And then F710, physician services and supervision, I've seen cited. And obviously they can pull in other ones as well, but these were the most common ones that I saw along with the 686 citation. And when you read the 2567s, they often started with this statement: failed to provide pressure ulcer preventative care consistent with professional standards, resulting in the potential for development of an avoidable pressure ulcer, worsening of overall deterioration of health status. After reading several dozens of 2567, there definitely were common themes. But the one that that I read the most often, I was surprised by, and it was heel boots that were not applied. So there are several mentions here that the resident didn't have them on according to the care plan. They couldn't be found. They weren't on. And then down here, there was also a dirty boot that was applied to an open heel wound. Other things that were cited where a care plan stated that the resident was be turned and repositioned and that he wasn't. The 2567, kind of goes along this lines, like 8 o'clock sitting in the Broda chair at the nurse's station, leaning to one side, left side, say, at 10 o'clock, same position, 12 o'clock, and they then assume that he was not changed or repositioned all shift. Treatments not being signed out on the treatment record, no pillows or wedges available or used for repositioning, and even residents that were not repositioned, undated dressings. And in one case, I read a missing dressing, and when they asked some more questions, the aide reported that it fell off and she just didn't tell the nurse. Care plans not being up to date, no pressure prevention interventions, or a care plan that not include the current treatment, lack of staff knowledge related to pressure ulcers, failure to notify provider of wound changes, and then not changing interventions when the wound was deteriorating. Here's some more. No weekly wound assessments, measurements, or staging or wound charting. And then along the same line is discrepancies between that charting and the wound log. Not following the schedule for positioning and turning. Not doing a Braden or a risk assessment. This one was a new treatment was ordered and it was not done. And when they looked further, this was a facility that was using point-click care. The order was entered into point-click care. However, they didn't click that little box that said to send it to the TAR, so that the nurse did not know that there was a new treatment order to do. And it was, I think, probably over a week, if I recall correctly, before the missing treatment was found. No evaluation of the effectiveness of new treatments, and then improper identification and classification of a wound. So several of these things we've already talked about, but how do you prevent getting a F686? We already mentioned admission assessment, getting that full body assessment done within 2 hours, and they have to look under the dressings. They can't just say dressing in place to the right hip. They have to look under it. They have to assess it, measure it, and if it's their facility practice, to stage it as well. And do a risk assessment like your Braden. And then weekly skin assessments need to be done, as well as weekly wound assessments. And I know this is always a challenge for facilities that have a program set up where your weekly shower skin assessments are done on Wednesday and your wound changes are every other day, and they don't always match up. My last facility, we had to go through and just really entirely redo things because I was looking at weekly skin assessments that say, no new areas of concern, dressing in place. And that didn't tell me anything. So we did some modifications to point-click care to make sure that the wounds were getting measured regularly. Look at your process for your orders. We talked about your formulary, making sure that the communication with providers is done, and make sure it gets documented so you can prove it. Communication to other team members, your CNAs, your nurses, keeping the care plan updated, having the supplies available. So that could be everything from wedges to wheelchair cushions, specialty mattresses, all your wound care supplies and dressing supplies, and staff needs to know where it's at. So there's no excuse on Monday that a dressing couldn't have been done because it was locked up. And if you can manage it, I do strongly recommend one person to oversee your wound care program. And even better still, if that person does your weekly skin assessments. That way there's continuity and consistency, and so much easier to tell if a wound is improving or deteriorating. Obviously, good charting, and as we mentioned before, wound care consultants, wound care certified nurses, and wound care clinics if you need one or you have that availability. Auditing is probably the other way you're going to know what's going on, checking those care plans to make sure that the preventative interventions are in place, making sure that your weekly skin assessments are done, your Bradens are done, checking your admissions to make sure that they have a very detailed skin assessment done, checking that the interventions that you have in your care plan are being done. This goes back to the boots. Are the boots on? If the resident has a specific turning schedule and you go and check and at 10 o'clock, they're supposed to be on their back and this person's on their right side, you're going to get caught and you're going to get cited for that. and then making sure that your treatments get done and they get charted. Staff education and competency assessments, we'll talk about here a little bit more in a few minutes. So I have another chat question here. Are there any other things that you have implemented to prevent F686 citations? Are there any other best practices that you have that we can share with other participants here today?
We had a question in the chat that I'll bring up at the end, but we had a program where, and I can't remember which particular provider had it, but they provided certain treatment, bandages and whatnot, and the protocol, as well as they provided a physician that came in and would do the wound rounding every week with their physician and their representative, but you always had to have a nurse. So that was really difficult to have the exact same person to go and do rounds with them to take them off the floor for staffing.
Right.
And I've had that at like 3 or 4 different facilities. So.
I think your bigger centers that have access to those physicians, as I mentioned in my first story about the foot ulcer, that was how we got out of this. This physician was, nationally published and everything, and had a program and devoted his career to nursing homes. But you don't see as many physicians that are specialty physicians that go out to facilities now. But if you have access to one, absolutely, that would be great.
Consistent people doing your skin assessments and measurements.
Absolutely.
That's
absolutely. Yeah, they look, they measure the tunneling different, making sure that you're measuring all the same way. Absolutely. And that's where your wound care logs get really wonky if you had different people writing on them. So, all right. Well, thanks for that input. So here on staff education, obviously on hire is critical.
One more was where
sure.
I used to work, we created a wound team that rounded weekly. I'm trying to do that here as well. Thank you, Jennifer.
Oh, that's a great idea.
It is, and including some of those key players that, like the dietitian, if they can do it, and then she's also certified in wound care, so that
very
makes
good.
a big difference too.
Some facilities that have dedicated mid-levels like PAs or NPs, they might even be able to include them in rounds. I think that would be great. And then you get the provider documentation in your charts as well.
Thank you.
And I guess the important thing about all that is that you all agree on the staging. One person can't be saying a stage 3 and another person a stage 2. So staff education on hire, CENA training nowadays, I don't think it's as good as it used to be. So I don't think we can assume that they understand why all these things we're asking them are important. And that's where I do like getting those pictures of wounds and showing them. I know they might be offended by them, but I think it explains to them why we want residents repositioned and what all the pressure on these bony prominences can do. And if they really care about their residents, they won't want that to happen to them either. And obviously annual refreshers, and nurses need trainings as well. I don't think we could assume that they understand or know either. Anytime you change your products, you get a new product, you change it, you change your policies or procedures. And if you identify that you have a problem with your program, you're probably going to want to do a performance improvement project, put something through QAPI, and you may want to do some additional in-service and education. Some resident care plans are so detailed and specific, you're going to have to go through them with staff as well to make sure that they perhaps know the special positioning and where to place pillows and wedges and that for each resident. So, those kind of things can be done at shift change and during huddles. CENA education, I put more detail here, thinking that you could use this for education as well, so that they understand to check the resident's skin with every contact, the importance of changing and toileting, how to use your skin cleanser. I don't think we can assume that, here's a skin cleanser, that they know how to use it and how to apply the skin protectants and where to find that and how to know what's on the resident's care plan and how to chart it. And that it is important to let the nurses know if the dressings fall off. They need to know to follow the care plan. We talked about heel boots, elevation of heels, making sure wheelchair cushions or whatever other types of support are needed in the wheelchair to help the resident maintain alignment and positioning. Keep linen wrinkle free. It might sound straightforward, but think about laying on a bunch of blankets that are all bumpy. That's and a lot of prolonged pressure on them. That could cause a pressure injury right there. And then limit the amount of linen under residents, especially if they're on those specialty mattresses, 3 or 4 lift pads and a couple briefs. And that resident's not going to feel the benefit of that specialty mattress, the airflow mattresses. So, I know sometimes they do it to save time, but it's not in the resident's best interests. Encouraging oral intake, helping them, finding out what they like, getting them their little treats. And of course, following infection prevention practices. This came from a source that I found that talks about the CNA's role and responsibility. And I think it's linked at the end, but it's a really good tool. And it talks about, that the aides need to know to tell the nurses about red areas that don't go back to normal color, that are painful to touch or hot, or an area that's pale and white and shiny, or anytime they notice anything that's changing in size and definitely getting worse looking or that may have an infection. The next 2 slides, I made a quiz for nurse aides that you can use if you like. I didn't include the answers where I'm assuming that you'll be able to figure them out. If you can't, let me know. And the nursing education for your licensed nurses, I think a good refresher on pressure relief and why it's important, and showing those graphics, just a reminder on why it's important. And it's important for them to help the CNAs if they can, so that residents aren't being dragged across linen, that they can be picked up and repositioned properly and carefully with less pain to the resident. And they need to pay attention when the nurse aides bring them a concern. I know it usually happens in the middle of med pass, but they need to write themselves a note. And as soon as they are able, they need to go look and see what the aide was talking about, and then follow up with the provider, get whatever orders are needed, making sure that care plans are updated. Keep the wound care nurse in the loop if you have one in your facilities. And then, of course, we talked about documentation according to your policies and procedures, and notifying physicians if wound conditions worsen. We know that facilities get citations for that. Aseptic technique for dressing changes, and don't forget to date and initial those dressings, following your orders, monitoring for signs and symptoms of infection. And I know I say this many times, but documentation's key. And then infection prevention practices. And obviously, if nurses by your facility practice on your policies are required to stage wounds and make recommendations for treatments, they need to have specialty training. Training, just from watching a webinar is probably not enough to know how to stage a wound or determine what type of wound it is. And that's where if you can have the luxury of a wound care certified nurse, and definitely one nurse that's monitoring your program, that's the best practice. There's also a quiz in here for your nurses, if you want to use that for a competency. So I think we can probably skip this one. Our time's kind of winding up here, but I was curious to see looks like a lot of people have dedicated wound nurses. Audits and monitoring. Best practice, obviously, is to have a pressure injury log. A lot of people, it's in their EMR. Some facilities have their own little Excel spreadsheet. Here are 2 tools that are very complex Excel spreadsheets, and they will do all kinds of calculations for them. They've got all kinds of tabs at the bottom. And then to evaluate your program, I would pull up the CMS critical pathway for pressure injuries. So it's pressure injury critical element pathway. I actually linked all the critical element pathways here. A lot of them have been updated as of April the 1st due to the enhanced barrier precautions requirements. And now for wound care, they are requiring a gown for wound care. This is a slide that talks about how to calculate your incidence of pressure injuries, the number of pressure injuries, and the number of residents in beds at midnight. The AHRQ has a great resource here on how to calculate them, and I did include an example here. This would be for calculating prevalence. MDS coding, which is in section M. I am not an MDS coordinator. I know enough as a director of nursing in my past life to know how important it is that the coding on the MDS matches the charting on your residents' wounds. And there are a couple sources here from your resident assessment instrument, as well as there was a source on Point Click Care. So just making sure that everything is matching up. Your quality remeasure report, if you've not seen it, ask your MDS nurse for it. It reports out your incidence of pressure ulcers, and there's a long stay measure and a short stay measure. And the long stay measure measures the percent of high-risk residents with pressure ulcers, and that will come to you in a percent. And then short stay changes in skin integrity post-acute care. And they've got pressure injury, pressure ulcer. Now your quality measures all boil up to factor into your star rating. And if you ever look at your star rating, there are quality measures, and then there's your staffing and your surveys, but it all contributes to that final star number that you have. So we're going to kind of wrap things up here now, talking about implementing an effective pressure injury prevention program. It starts at the top. Leadership needs to acknowledge the importance of your program. They need to support it. They need to know how many pressure injuries you have. They need to know what's on your quality measure report. And if you have a wound care team, definitely a director of nursing, but if your administrator would participate, that would be even better. Providing care to these residents does require a commitment when it comes to resources. So equipment, that's your specialty mattresses, your specialty cushions, making sure you have the wound care supplies. Education, send someone who has an aptitude and an interest to get wound care certified. Send your nurses to conferences or find webinars that they can learn more about skin care. And as I mentioned, I strongly encourage you to have one person assigned to your wound care program that will monitor it, maintain your log. And we already talked about our log, and making sure that your policies and procedures are based off of your evidence-based guidance. And for wound care, it's going to be your National Pressure Injury Advisory Panel, just like for our infection control issues, it's your CDC. And you need to look at your policies, look at your processes and your practices. When you have your orders, we talked about the templates, making sure that all those interventions get put on the care plans. Who's going to update your care plans for your wounds? Is it the wound care nurse, the floor nurse, the MDS nurse, the DON? Who's going to do that? And then we talked about measuring wounds and staging, communication to providers, to residents, to families, updating your nurses and aides, and the auditing to make sure that your care plan interventions are being done. We all know the importance of education for nurses and CNAs. I would do competencies for your CNAs when you do your competency evaluations. Make sure that they know how to position a resident on their side. We can't assume that they know how to place those pillows. Do competency evaluations on the procedures of your nurses doing your wound care. Are they following a septic technique to try and prevent infection as much as possible? And all your results, and especially if you have a performance improvement going on, should be reported up to your QAPI committee. So just a couple summary statements here. I believe that preventing pressure injuries is a team effort, but there are a lot of resources out there for you. Here, we have 2 slides at the end here on things that I found were most pertinent, a lot from the National Pressure Injury Advisory Panel. This one was from the AHRQ that I mentioned about how to measure. There's an article here on terminal ulcers, the critical element pathway. Joint Commission has some preventative pressure injury recommendations. Here's a couple links on education. This one was the one I talked about at the Cena's role and responsibility. Superior Health has some education modules under frontline forces. This was actually a pretty good YouTube video as well. And the Wisconsin Health Department has a link. Minnesota has some information too, but not as much as Wisconsin. And then here are the 3 articles on the formulary. And again, I'm not recommending any of them, but they were some useful information there. So I appreciate your time. We are curious though, if you would like future sessions to include more information on pressure injuries, and we will try and find somebody appropriate to do that presentation for you. If you would put that in chat for us.
So we did have some questions. The first one being when you were discussing about removing the dressings and making sure you get them off in the first 2 hours to inspect the skin underneath. What about surgical dressings that come with orders not to remove until follow up with the surgeon? Same.
I would not remove them.
Okay. And then it was a question. They talked about nurses absolutely needing training, agreed 100%. So one suggestion was utilizing the Metastar wound and skin education program that we have. I said that's a great one, obviously.
Yeah, can you put that link, can somebody put that link in chat, or do you have it, or?
Is Jenna Heim still on here? If you are, can you put that link in chat? Otherwise I will find it.
I am still on here. And people can email me. I'll put my email address in the chat. If you're interested in that back to the basics pressure injury prevention skin fair, it's available for all facilities in Wisconsin. Feel free to email me and I can get you the information you need.
All right, thanks, Jenna.
Yep.
One other comment was I found that CNAs think some barrier cream, and I lost the comment because somebody put something in there. Some barrier cream is good, but a lot more is better.
Yes, I agree. And that's where I talked about, don't assume they know how to apply, use your Pericare spray, don't assume that they know how to put your cream on. Yeah, I've seen that in case, trying to get off that zinc oxide is sometimes really, really terrible. So they need to understand the rationale behind it. And I think with some explanations, they don't want to create problems. They really do want to take care of the residents, I do believe.
And then yes, yes, and yes is the answer.
Okay.
Yeah, Patty, this is Jana. I just wanted to say to that point, like you've talked about with the barrier cream, you and I had talked about earlier last week about actually having them practice with it as nursing assistants. Practice. Have them demonstrate how they do pericare.
Yes. That would be a
fully care, and applying barrier creams. You can, if you actually have an education that shows exactly how much, what coverage you kind of want, and giving them an idea of what that looks like when they're actually doing it to a mannequin or a person.
Yeah, absolutely. And then removing it and how to practice what the product looks like when it's removed and how to remove it. So very good.
Absolutely.
I do have a quick question just because I came up, I had also an example, but basically, when we talk about the pressure injuries and sometimes not knowing where the pressure is coming from or where the injury came from, then that abuse tag comes in there too. And so one example I have is that we had a resident who she did get gravy spilled on her thigh. And so she got a 2nd-degree burn. And so there was a wound there. So we knew where it was coming from. We started a treatment plan and all that good stuff. But the wound wasn't getting better. It was actually getting worse. What we found out based off social worker doing some observations of her behavior, that she was actually picking at it. So then we had to do a care plan. So when we talk about things like that, how important and how do you mitigate when there is some injury of unknown origin and the investigation piece of that?
It's asking all the questions. Like you talked about, unknown origin, you have to make sure that you're doing that deep dive, that you are talking to absolutely everybody. to make sure that they don't have any idea what happened. And sometimes those interviews can take quite some time because one person might say something that leads you to another person that leads you to another person. I think we've all had to do the reports to the state, about those injuries. And sometimes if you can find out what really did happen, you might not get a citation for it. So it takes time, it takes a team, but it's
Right.
possible.
And I think, Patty, that's what the past non-compliance, putting something like that into past non-compliance and working the root cause quality improvement process helps.
Yep.
And I
Very
also
good.
love that you talked about the team and working as a team, because it was a social worker who said, hey, can we just do some observations of her behavior? Now, a lot of times we will leave pressure ulcers to nursing, but it might be someone else who saw something happen. So thank you for talking about that.
No, I'm a big believer in team for absolutely everything. You cannot underestimate what that housekeeper heard when they're in the room, or the maintenance guy when he was fixing something. Is just really, really important. So
those admission assessments when you're first coming in, it's really important not only to get those, your immunizations and your baseline skin, but it's also important to assess the risk behind those things. If we have somebody that is, not having, not compliant with things, those risks behind them, and getting those and continually doing that risk assessment and risk negotiation and mitigation for those risks is really, really important too.
yeah, document. I know it takes time, but it will help you. We've got about 2 minutes here. Are there any other comments or questions? Feel free to email me if you have any questions, or any member of Superior Health, and we're happy to help you.
It's also important that we make sure that we mention we still have the mobile vaccination clinics. While I'm waiting for some questions to come in, we have the mobile vaccination clinic. Don't forget that the definition of up-to-date COVID-19 vaccinations for people 65 and older has changed and reset. Will reset your NHSN rate to 0% if you're not getting that second vaccination with it or after 4 months of the last vaccination. So just a reminder. And then if you're interested in the mobile vaccination clinics, it's immunizations at superiorhealthqa.org to email for. Sorry. And I think you got a lot of compliments in the comments. And I think that's all I had for questions.
Well, I appreciate everybody's time today. I know everybody's very busy, and I appreciate your participation and joining us. So we'll see you again soon.
Before we conclude, I just want to remind you that next week, our next presentation will be on April, or not next week, I apologize, April 24th at 12 Central Standard Time, 1 p.m. Eastern Standard Time, where we will be diving into improving, maintaining, preventing incontinence with a special presentation streamed by Impera with Miss Heather Johnson presenting. Today, a link to the after evaluation is being dropped into the chat. Please take just a couple of seconds before to fill that out. It helps us to improve, helps us know what you're looking for in these roundtable events. So just take a second to fill out that feedback. And this will conclude for our presentation for today. Thank you so much, everyone.